So, welcome to this deep dive. Today, we are focusing on something that really transforms a practice, which is mastering facial skeletal augmentation with alloplastic implants.
Right. It's such a high leverage topic.
Totally. Because, we're stripping away the old dogmas today. We're looking strictly at how you select the right hardware, how you execute that exact surgical pocket, and ultimately achieve flawless contouring.
Exactly. Because in this specific subspecialty, I mean, just 2 or 3 millimeters of skeletal projection, it completely transforms the entire gestalt of a patient's face.
Yeah, it's wild how much of an impact it has.
It really is the ultimate surgical leverage. You make this microscopic change at the skeletal base, and it translates into these massive volumetric shifts in the overlying soft tissue envelope.
Right, but before you even pick up a scalpel, right, before you check for any pre-existing ptosis of the eyelids or, map out the vascularity, your preoperative aesthetic goals have to be grounded in actual reality.
Oh, absolutely. And that means a total departure from those arbitrary neoclassical canons.
Yeah, those old Renaissance and Greek proportions, they're practically useless in the modern clinic.
They really are. I mean, if you systematically measure the faces that society currently deems highly attractive, you almost never find those theoretical mathematical proportions.
No, you don't. You really have to rely on anthropometric measurements of normal faces paired with high-resolution CT data to guide your baseline.
Right. You plan the procedure tailored to the individual's unique topography, not, some textbook drawing from the 1800s.
Exactly. And that tailored approach leads directly into what is probably the single most critical moment of the preoperative consultation.
Oh, the asymmetry talk.
Yes. Here's the key point. Every single human face has underlying skeletal asymmetry, period.
Right.
If you do not explicitly recognize that asymmetry and physically point it out to the patient in front of a mirror preoperatively, you own that asymmetry postoperatively.
You absolutely do. Common pitfall right there.
Yeah.
In real life, we have all seen this. The patient comes into the clinic at week 3, swelling is coming down.
Oh, yeah, and they hand you a mirror.
Exactly. They hand you a mirror and they point to a 1 millimeter difference between their left and right malar eminences.
And they don't see it as their natural anatomy.
Nope. They interpret it as your technical error.
Yeah. But you completely avoid that medical, legal, and psychological headache just by documenting their baseline asymmetry on day one.
It's so crucial. So,
Yeah.
Once those expectations are locked in and documented, the focus really shifts to hardware selection.
Right. And, the shift toward alloclastics over autogenous bone in these aesthetic applications, it really comes down to predictability.
Exactly. I mean, you do not have the donor site morbidity of harvesting from the calvarium or the rib or the iliac crest.
Nobody wants that if they don't need it.
Right. And more importantly, unlike vascularized bone grafts or free bone grafts, synthetic materials they don't unpredictably remodel or resorb under the soft tissue envelope.
Yeah, you place a 3-millimeter implant, you get exactly 3 millimeters of long-term projection.
Exactly.
Yeah.
The host has no enzymatic machinery to degrade these synthetics.
So instead, the body just isolates the foreign material by forming a fibrous capsule.
Right, and here's the thing. The surface topography of the implant you choose dictates the exact biological nature of that capsule.
Yeah.
Which dictates your long-term success or failure.
Yeah. Let's talk about solid silicone, because a lot of surgeons still reach for it out of habit.
Right, vulcanized polysiloxane. I mean, it is cheap, it is easy to carve with a standard scalpel.
And because it's perfectly smooth, it slides effortlessly into a tight surgical pocket.
Yeah, and if you get an infection, pulling it out takes seconds. But the physiological reality at the bone interface is highly problematic.
Yeah, the smooth surface is precisely the issue. Common pitfall with solid silicone. It causes profound underlying bone resorption over a decade.
Oh, the windshield wiper effect.
Exactly. The overlying soft tissue mechanical forces. So every time the patient smiles, chews, speaks, it translates into micromotion. The implant acts like a windshield wiper on the cortex of the bone, creating pressure that just leads to resorption.
And on top of that, the fibrous capsule that forms around silicone is really dense. It's bursa-like.
Right, and that smooth bursa can easily become visible or palpable under thin soft tissue coverage.
Yeah, it creates this very unnatural, stuck-on appearance.
Which is not what anyone wants. So, stepping up the ladder of tissue integration, you have polytetrafluoroethylene.
Gore-Tex.
Right, Gore-Tex, which is flexible, non-cross-linked, and the pore size is engineered between 10 and 30 micrometers.
And that specific micron range completely changes the game biologically.
Yeah.
A pore size of 10 to 30 micrometers actually allows for mild soft tissue ingrowth.
Right. The host fibroblasts can penetrate the outer layer.
Exactly. So that means a far less dense fibrous encapsulation and a significantly reduced tendency for the implant to migrate, especially compared to smooth silicone.
It anchors itself just enough to resist that dynamic muscular pull.
Yeah. But when you need absolute rigid stability, the heavy hitter is high-density porous polyethylene.
Medpore or synpore?
Right. It's a simple carbon chain of ethylene monomer. It's incredibly firm, resists compression from the soft tissue, but it retains just enough flexibility to adapt to the skeletal contour.
And the pores are massive compared to Gore-Tex. We're talking 125 to 250 micrometers.
Which allows for extensive fibrovascular ingrowth. The tissue doesn't just anchor to the surface,
Yeah.
It integrates entirely through the matrix.
Yeah, the implant practically becomes part of the native skeleton. It completely resists migration.
It doesn't erode the underlying bone because that micromotion is eliminated. And crucially, it takes a titanium screw beautifully without fragmenting.
But I mean, I know there is hesitation around porous polyethylene in some practices.
Oh, for sure.
Because, like, the soft tissues adhere so aggressively. So if you have an infected or malpositioned implant, the dissection required to remove it is just brutal.
It is. You are meticulously dissecting it off the bone and the soft tissue, literally piece by piece.
Right. So if it's so hard to take out, isn't that a massive liability if something goes wrong? Like, if you place it asymmetrically, revising it is a total nightmare.
It is a valid concern, yes. But the trade-off is the 0% migration rate.
Right.
The stability you gain and eliminating that bone erosion really makes that calculated risk highly worthwhile in a dedicated facial contouring practice.
That makes sense. Which means, obviously, your material choice dictates your surgical technique. You can't place a porous implant using old-school methods designed for silicone.
No, definitely not. The surgical execution relies on this very specific triad: the plane, the pocket, and the fixation.
Okay, let's break this down. First, the plane.
The plane of dissection must always be subperiosteal. You have to strip the periosteum and stay right on the raw cortex.
Because it's a relatively bloodless plane, right?
Right. Yeah, it's bloodless. It shields the overlying neurovascular bundles within the elevated flap, and it just gives you optimal, uncompromised visualization of the native skeletal topography.
Okay, what about the pocket size? Because the historical teaching was always to dissect a tight pocket.
Right. Just barely big enough to squeeze the smooth silicone implant in, relying on the soft tissue envelope to keep it from shifting.
Yeah, you have to completely abandon that tight pocket mindset for porous implants.
Totally. Porous polyethylene acts like Velcro against the soft tissue the second you insert it.
Yeah, you cannot slide or massage it into place once it is in the pocket.
Nope. So you need a wide subperiosteal dissection. You have to open the exposure wide enough to clearly visualize the entire skeletal anatomy.
You have to ensure your placement is perfectly symmetric before you commit to the position.
Exactly. And that wide exposure sets you up for the most critical step of the operation. Here is the key point. Screw fixation is non-negotiable.
Yeah, because faces have these wildly unique, undulating surface topographies.
Right. If you just lay an implant flat on the curved maxilla or the mandible, portions of it will not conform. You end up with dead space between the implant and the bone.
And unpredictable augmentation gaps are the enemy of precision.
They really are. I mean, if you plan for a 3-millimeter projection, but the dead space behind the implant adds another 2 millimeters.
You suddenly have a distorted 5-millimeter overcorrection.
Exactly. So screws physically winch the implant flush against the bone, completely obliterating that dead space.
And rigid fixation also allows you to perform final contouring in situ, right?
Yes. Once the titanium screws are driving that implant into the cortex, you can take a high-speed burr or a heavy scalpel and literally feather the edges directly on the skeleton.
Because the margins must taper imperceptibly into the native bone. In real life, if you leave a palpable step off.
Oh, the patient will feel it every single morning when they wash their face.
Yep, and they will fixate on it.
Absolutely. Now, it's just a brief clinical note on the operative setup. While you can technically numb a patient and do minor contouring under local anesthesia, general endotracheal is heavily preferred.
Yeah, you are working deep in the malar midface and the mandible, relying almost entirely on intraoral mucosal incisions.
Right, so securing the airway with an endotracheal tube allows you to aggressively prep the oral cavity with betadine or chlorhexidine washes.
which drastically minimizes the bacterial load and the subsequent infection risk. So taking those principles, the wide subperiosteal pocket, the fibrovascular integration, rigid screw fixation, the regional application changes based on the local anatomy.
Let's start top down with the midface.
Okay, Meller augmentation. The workhorse approach is intraoral via an upper buccal sulcus incision.
But the precision of that incision really matters. You have to stay far enough away from the actual apex of the sulcus to leave a generous cuff of labial tissue.
Because if you don't leave that cuff, you cannot achieve a watertight, tension-free closure.
Exactly. Which is basically an open door for oral flora to infect the porous implant.
Right. So you carefully elevate the periosteum, meticulously avoiding the division of the levator labii superioris and other lip elevators. You protect the infraorbital nerve and carry the dissection over the malar eminence onto the zygomatic arch.
Yep. And, when patients present for revisions of malar implants done elsewhere, they usually have the exact same aesthetic complaint.
Right. The implant creates this bizarre feline appearance.
Yeah. Usually because it was either oversized or, more commonly, it was allowed to drift too far laterally.
In real life, an unfixed implant shifting laterally creates this exaggerated, artificially wide midface that just reads instantly as surgical intervention.
Exactly. Precision in your initial positioning and immediate rigid screw fixation locks the implant over the eminence, preventing that lateral drift entirely.
Okay, moving slightly medial and inferior. The paranasal region. This actually offers one of the highest satisfaction rates for a specific cohort.
Oh, yeah. Patients presenting with midface concavity, that sunken appearance around the piriform aperture, but who possess completely normal, class 1 dental occlusion.
Right, because the traditional orthognathic approach for a retruded midface is a Lefort 1 advancement.
Which is massive, fracturing the maxilla, plating it forward, significant morbidity, hospitalization, recovery.
Yeah, but by placing porous implants via an upper gingivobuccal sulcus incision, you simulate the aesthetic visual effect of a Lefort 1.
You achieve that robust central facial projection, effacing those deep nasolabial folds, and it's entirely an outpatient procedure.
It is such a powerful structural camouflage. Now, moving up to the infraorbital rim, the dynamic changes again here.
Right, this is the territory of the negative vector face,
Right.
where the cheek mass is positioned posterior to the cornea.
Leaving the eyes looking overly prominent and unsupported, so augmenting that rim provides the necessary skeletal support to the lower eyelid.
It reverses that tired proptotic appearance,
Yeah.
but the surgical access is notoriously difficult.
Yeah, relying solely on a transconjunctival incision is just insufficient. The exposure is too limited to see the entire complex geometry of the rim.
You cannot easily manipulate a drill or place titanium screws or burr the margins of a medpore implant through a tight transconjunctival window.
No. You really need a subciliary approach or a formal skin muscle flap to achieve the wide exposure necessary for precise fixation.
Especially in the periorbital region, where even a fraction of a millimeter step-off is visibly disastrous.
The tissue tolerance for error in the lower lid is practically zero.
Exactly. Now, the forces and constraints completely shift as you move down to the lower third of the face.
The chin and the mandible. It's a highly dynamic environment. Heavy muscular forces constantly acting on the skeletal base.
And this is also where alloplastic implants frequently compete head-to-head with traditional bony osteotomies.
Yeah. The ideal profile metrics for the lower face are pretty well established. The soft tissue goal is to have the upper lip projecting approximately 2 millimeters beyond the lower lip.
And the lower lip projecting 2 millimeters beyond the chin point.
Right. So when addressing a deficient pogonian, implant selection is critical. The old-school small button implants that only cover the central mentum. They're obsolete.
They fail entirely because they do not address the lateral jawline. A button implant creates an abrupt transition, and it looks exactly like a piece of plastic adhered to the front of the jaw.
Yeah. The standard of care requires two-piece extended porous polyethylene implants.
Right, featuring long lateral extensions that taper smoothly along the mandibular body, integrating the chin projection into the wider jawline.
And the genius of that two-piece design is the central connecting hinge.
Exactly. Instead of forcing a rigid block against the bone, the hinge lets you actively adjust the arc of the implant in real time.
You literally bend it so the inferior border perfectly tracks along the inferior border of the native mandible.
But securing that safely requires the correct surgical approach. A submental incision is far superior to the intraoral route.
Right, because intraoral chin approaches carry massive, unnecessary risks here.
Oh yeah. Dissecting down through the mouth risks stripping or entirely dividing the mentalis muscles.
which can lead to a devastating lower lip ptuosis. You are also operating blindly near the mental nerves, risking traction injury.
Plus, trying to force those long lateral extensions of the implant through a tight intraoral pocket and blindly guiding them along the mandibular body, it's incredibly imprecise.
A submental incision bypasses all of this. You access the inferior border directly, you leave the mentalis origin pristine, and you slide the lateral extensions accurately under direct vision.
Yeah, but the clinical debate always surfaces here, right? Implants versus sliding genioplasty.
Oh yeah, sliding genioplasty is a deeply powerful structural operation.
You execute a horizontal osteotomy roughly 4 millimeters below the mental foramen, free the chin point, and physically advance the bone.
Right. Think of sliding genioplasty like remodeling the foundational concrete of a house, whereas an alloplastic implant is like adding new architectural siding.
That's a great analogy. Genioplasty alters the true architecture. It is unparalleled for vertical elongation, specifically when you need to efface a deep labiomental sulcus.
And advancing the bone pulls the attached suprahyoid musculature forward, dramatically tightening the submental contour and often improving airway patency.
It's powerful, but the aesthetic pitfalls are severe.
Right, the step-offs.
Exactly. When you advance that isolated chin segment, you inevitably create unnatural bony step-offs laterally, right at the osteotomy sites.
And in patients who already have thin, soft tissue or pre-gel sulci, those sharp bony indentations look disfiguring.
Not to mention it requires highly precise bone carpentry. I mean, if the angle of your oscillating saw is off by just a few degrees, you unintentionally lengthen or shorten the vertical height of the patient's face.
Mandible implants bypass that carpentry entirely, and they are generally utilized across 3 very distinct clinical profiles.
Right. The first is the aesthetically motivated patient seeking a hyperangular, defined jawline.
You are simply increasing the bigonial distance to create that sharp, model-esque lower face architecture.
The second profile involves the skeletally deficient patient. These patients present with an obtuse mandibular angle, a steep mandibular plane, and vertically deficient ramus dimensions.
So combining a custom mandible implant with an extended chin implant comprehensively camouflages that complex 3D deficiency without breaking the jaw.
Exactly. And the third profile highlights the true reconstructive power of these materials,
Okay.
the post-sagittal split osteotomy patient.
Right, so a patient undergoes a bilateral sagittal split advancement to correct a severe class 2 malocclusion.
The orthognathic surgeon advances the tooth-bearing segment to fix the bite.
The functional bite is fixed, but that forward movement inevitably creates a profound contour irregularity.
Yet you are left with a literal narrowing or a harsh bony step-off right at the body osteotomy site.
The soft tissue drapes into that void, leaving the jawline looking pinched and disfigured. But custom CT-designed porous implants resolve this perfectly.
They do. You take a high-res scan of the post-osteotomy defect, use CAD software to design an implant that perfectly fills that specific bony void, and you camouflage the step-off entirely.
Restoring a continuous jawline, it's incredible. But the operative technique for placing these large mandibular implants requires precision.
Absolutely. You make a generous intraoral mucosal incision, intentionally placed at least a centimeter above the depth of the sulcus to preserve tissue for closure.
You dissect down, meticulously protect the mental nerve, and then you must entirely strip and free both the inferior and posterior borders of the mandible from the heavy pterygomasseteric sling attachments.
Right. You cannot just slide the implant under the muscle. The pocket has to be widely released.
You trim it if necessary, adapt it, and fixate it with multiple titanium screws so it cannot rock under the force of the masseter.
Enclosure is just as critical. 2 robust layers with absorbable sutures, averting the mucosal edges for a watertight seal.
And always use a postauricular suction drain, tunneled through the subcutaneous tissue, to evacuate any hematoma.
For sure. So all of this logic applies to augmenting deficient bone. But a major clinical challenge arises when the underlying skeleton is perfectly normal, but the patient suffers from severe involutional soft tissue depressions.
Like a deep submalar hollow, a prominent pre-gel sulcus, or a skeletonized tear trough.
Right. So the question is, can you use a hard skeletal implant to mask soft tissue volume loss?
You can, but here is the golden rule of soft tissue camouflage. You must be wildly conservative. Skeletal projection and soft tissue volume do not translate on a one-to-one visual ratio.
Right, this is a trap a lot of surgeons fall into. The visual physics of the face dictate that 5 millimeters of soft, yielding fat padding looks entirely different than a 5 millimeter thick piece of rigid polyethylene bolted to the maxilla.
Yeah, hard skeletal projection reads visually as bone. If you try to replace a thick fat pad with an equally thick implant, the face will look harsh, skeletonized, and totally unnatural.
Exactly. Tread lightly when substituting bone for fat. And, the temporal region presents a similar volumetric challenge.
Yeah, temporal concavities, whether from natural senescence, extremely low body fat, or post-surgical atrophy following the deep plane dissection of a facelift.
Right. To fill the temporal fossa, we actually pivot away from prefabricated polyethylene and rely on polymethyl methacrylate, or PMMA.
Which functions basically as a moldable bone cement.
Exactly. You mix the polymer powder with a liquid monomer, it initiates an exothermic curing process, and you manually mold it to the exact dimensions of the defect before it sets hard.
And the critical operative decision there is identifying the correct plane of placement. If the patient has virgin tissue in the temporal region, you use a small hidden scalp incision and place the PMMA deep beneath the temporalis muscle.
Right, correctly on the calvarium.
Yeah.
The muscle provides excellent natural soft tissue coverage over the cement.
But if the patient has had previous facial surgery that altered or scarred that deep submuscular plane, you do not fight the scar tissue.
No, you place the PMMA superficial to the altered temporalis muscle. You mold it precisely to blend into the adjacent fossa, and then you must rigidly fixate it with titanium screws along the dense bone of the lateral orbital rim.
Right, because if you merely lay the PMMA over the muscle without screw fixation, the constant dynamic flexing of the temporalis during mastication will eventually shift the implant.
And as we said, motion is the enemy of all alloplastic implants. Rigid fixation ensures that temporal reconstruction remains symmetric and permanent.
So, kind of reviewing the entire landscape of these procedures, the data on complications is incredibly clear.
It is, because materials like Gore-Tex, Medpor, and PMMA are highly biocompatible and lack the proteins to trigger host rejection. True allergic or rejection reactions are extraordinarily rare.
The reality is that almost all complications are technique-related.
Yep. The surgeon chose an inappropriate size, failed to contour the margins to obliterate step-offs, neglected rigid screw fixation, or dissected an asymmetric pocket.
And in the event of an acute infection involving a porous alloplast, there is no heroic salvage protocol.
No. You cannot wash it out and hope antibiotics clear a biofilm deeply integrated into a porous matrix.
The definitive, non-negotiable treatment is the immediate surgical removal of the implant.
Period.
Yeah.
You must excise the material, allow the local tissues to fully heal, contract, and clear the infection, and plan for a secondary reconstruction months down the line.
You simply cannot negotiate with an infected alloplast.
No. The discipline required is immense, but the capabilities we now have with these materials literally rewrite the reconstructive algorithm.
We are absolutely operating in an era where custom CT-guided porous implants perfectly camouflage highly complex skeletal defects, correcting post-surgical deformities with millimeter precision and minimal downtime.
It's amazing.
Which kind of leaves you with a profound question to chew on before you scrub into your next facial contouring case. With alloplastic camouflage becoming this powerful, this predictable, and carrying just a fraction of the morbidity, are we rapidly approaching the point where complex, morbid orthognathic bone movements are completely abandoned in favor of custom implants for patients whose concerns are purely aesthetic? Something to think about the leverage you hold the next time you evaluate a jawline.